It's my pleasure now to introduce Professor Tan Tong Cheung from Hong Kong. He is the chief of the HPB division in Queen Mary Hospital in Hong Kong and member of the board of directors of Hong Kong Liver Foundation. He will speak about mini invasive hepatectomy in HCC.
Thank you. Okay, I'll start. Open liver surgery is a conventional standard practice on the left-hand side. In the past 10 years for big tumor, we try to remove the left side of the wound, but of course we can also do it through pure laparoscopic approach, and the tumor will be delivered through phalansteal incisions. So I think in 2014, the Montreal consensus meeting actually made a difference. So after this consensus meeting, the number of laparoscopic liver resections rapidly increased. And at that time, we think that minor liver resections is to be a standard practice. Why are we so conservative? Is because of people sitting on the first row, right? Actually, at that time, they object to major liver resection, but time passes. Many people on the first row, they agree that laparoscopic liver resection is, even through a major liver resection, is a good practice. So in Hong Kong, we also have a consensus meeting showing that in 2018, Professor Ho San Hang is also one of the chairmen in the meeting, showing that we have improved techniques in doing laparoscopic liver resection for HCC, and the standard practice in my hospital, dated back 20 years ago, my teacher, Professor S.C. Fan, said we have to do zero mortality during hospital stay, and that become a very high benchmark in my hospital, so that when we are doing laparoscopic surgery, we also keep in mind that we should follow this practice. So keyhole surgery, we can do it nowadays also using robotic approaches. This is a Da Vinci Xi system, the setup in my hospital. This is one of the, okay, this is one of the video. Okay, stop. Okay, right posterior sector was not. Okay, anyway, robotic liver resection and also minimally invasive approach using a different method. I think we all understand that there is also in favor of operation time, the number of blood loss, and also the blood transfusion rate, zero resection, I think is all similar when comparing to robotic liver resection and also laparoscopic liver resections. Complication rate, I think is all similar, but also we understand that different sector of the liver is also with a different type of difficulty scores. For patients, because we are inserting laparoscope in the umbilical area, so what we see unlike open surgery is we look from the foot end of the patients, and that makes the superior segment of the liver more difficult to operate. So I think this is many of the collaborative study just now Brian Go has presented. Okay. And also we have analyzed in our group, and we have also analyzed around 800 cases with big tumors. Just now, Savi said maybe big tumor may be difficult, but to my surprise, we also found that actually quite a large number of cases has been done all over the world using both laparoscopic and open approaches. Okay. Right. So this is an international study that we have conducted for tumor bigger than 10 centimeters. I can see most of the cases are actually from Asia Center and European centers. There were 4 sites in the USA and 1 site in Brazil. After propensity score matching, we found that this is actually a safe operations, but in the laparoscopic group, we found that there was 4 mortalities, 1.8%, and there was there was non-hospital mortality in the robotic group. And we can see that the median age is around 54 years old, and ASA are all good. Okay, we found that the patients has median operation time. Okay, this is a characteristic. The tumor is around 37% of the patients are HCC, and also because in Europe they have more colorectal lymph metastasis, and around 80% of the patients have a liver cirrhosis, and Some of them are with severe portal hypertension. The median tumor size is 11 centimeter in size. Some of the patients has more than one tumor. If you classify according to the IASGO score, many of these categories fall into expert level of difficulty and also high difficulty. The IMM score also classified, and most of it is a class 3 difficulty. And we found that many of the patients actually had major liver resections, and some of the patients, if located in left lobe of the liver, they can be handled with left lateral sectionectomy and wedge liver resections. Blood loss, I think, after propensity score matching is similar. 200 ml in robotic group versus 300 ml in the laparoscopic group. And also we found that the median operation time is actually shorter, okay? It's even though statistically not significant. So I think the robotic group, why is it shorter? Probably they have, these are selected. Maybe there may be bias, right? People are more experienced, they then switch to robotic doing difficult operations. But for entry-level laparoscopic surgery, probably even the younger surgeons can participate. So I think there is a difference in the two group. Conversion rate is 8.2% in the robotic group versus 10%, 11% in the laparoscopic group. 30 days readmission is all similar in two groups, but there's a tendency and trend that in favor of a robotic group. After propensity score matching, we see that the complication rate is 28% versus 21%. After justifications using Clavian-Lindo classifications more than 2, we found that is a 4.1% versus 9.6%. Reoperation rate is low in both groups. 90-day mortality is at 2.7% in laparoscopic group versus 0% in robotic group. Okay. Oh, I think there should be a video here, but it's gone. Okay. During the era of COVID, we have a long waiting time for patients waiting for XCC, and we have introduced a study using immunotherapy to treat patients with XCC while they are waiting for surgery. So this is a new adjuvant approach. This is 20 patients has been enrolled to this study. The median age is 65 patients. 70% of them are HPV carrier. And we found that 20% of all the patients in Charles A liver cirrhosis, the median tumor size is 11.8%. Portal ring thrombosis in 2 patients is a segmental portal ring thrombosis. AFP level is high, elevated, and in 40% of the patients. All of the patients actually undergone liver resections. Most of the patients, 80% of them are undergoing major liver resections. Blood loss is around 1.5 liter for a very big tumor. Not every single patient needs blood transfusions. Okay. The median size after liver resection, we measure the pathology, is 13%. None of them has an involvement of the margin. All of them have R0 liver resections. And to our surprise, actually, we found that 50% of all the patients actually after 3 doses of anti-PD-1 therapy in the pathology, they show significant pathological responses. And actually 3 of the patients has a more than 90% of pathological response. You can see that the red color is actually the patients with a different level of necrosis after therapy. This is one of the patients with a 5.9 centimeter tumor. After 3 cycles of treatment, it reduces to 4.6 centimeter, and the pathology show complete necrosis. This is another patient, 15.5 centimeter. After 3 cycles of treatment, it reduces to 12 centimeter. And after liver resections, actually we can see that there is a no recurrence after surgery. And that actually this one, we use a minimally invasive approach to take out the tumor. And you can see that from this table, patients responding to immunotherapy, they have significant hemorrhagic necrosis and also significant T-cell infiltrations, signifying they are responder to patients with immunotherapy. This is another patient showing a significant necrosis, and also there is no viable cancer cell after the treatment. So this is a complete response after 3 doses of immunotherapy. But of course, for big tumor, the recurrence rate is higher. Okay, we see that 3 patients in the responder group actually they have recurrence. Okay, but in the non-responding group, they have higher chance of recurrence. This is one of the patients with very big tumor in the segment 8 of the liver. Okay, it's a 10 centimeter tumor. So after cholecystectomy, we control the hepatic artery. Okay, we clip it and divide the hepatic artery, and then control the right portal vein. Okay, and then we clip it, and we can see the demarcations. Okay, of the tumor. Okay, and then we use our ultrasound to map the area. Using the ICG camera, actually we don't see enhancement of the tumor, because this patient actually had immunotherapy for the treatment, and then it should be enhanced on the ICG camera, but to our surprise, we don't see any immunofluorescent enhancement. Okay, and we take out the right hepatic vein. Okay, the big tumor on the right should be over this area, and then we separate, because of a big tumor there's adhesions on the diaphragm. Okay, and we take this out and we send for pathologic analysis. This patient also shows significant tumor necrosis. That's why it's not picking up ICG in this scenario. So this is another patient with a tumor. Okay, in the segment 4A of the tumor. This patient also received immunotherapy and also targeted therapy. So during the transaction, actually, we find that for patients with good responding to the targeted therapy, they have more vascular adhesions. Okay, when we are dissecting using the prosopic technique, I think we go into a new era that we are facing more and more this type of patients. During dissection, probably you have to be careful, right, about the dissections of the neovascular formations in this group of patients. So I think both robotic and laparoscopic liver resections nowadays can be safely performed in patients with selected centers. I think the volume of the center is very important. I think if this patient can be operated by minimally invasive approach or robotic approach, is already marked during the meeting you make before the surgery, and you read the film, you understand whether you can do it or not, right? Or we will not try a laparoscopic approach if we found that this is upfront not a suitable candidate for minimally invasive surgery. So in those scenarios, we'll just open and operate in those patients. Thank you very much for your attention.
Thanks a lot, Dr. Cheung. Any question from the floor? Any comment? Yes, please. Yes, you can use this one. Introduce yourself first.
Yes, Safidok Mac France. Thank you for presentation. I have a comment because you present some cases.
Mike, please.
You present some cases after immunotherapy, and I think that neoadjuvant treatment by immunotherapy or radioembolization or everything will probably increase the proportion of patients who we cannot resect. they will increase the proportion of patient, because if you have a larger tumor behind the vessels, if we decide to operate minimally invasive limit, we go for open. If we give neoadjuvant treatment, we can have tumor shrinking, and we can operate in this patient by laparoscopic or by robotic. So I think one of the advantage of neoadjuvant treatment is to increase the proportion of patient in whom we can operate by minimally invasive approach.
Yeah, I think there's two concepts. One is conversion therapy, downsaging from unresectable tumor to resectable tumor. The other is a neoadjuvant plus adjuvant therapy, that is a perioperative therapy. I think nowadays why it is so difficult to decide on immunotherapy is there is no biomarkers. In the Western literature, it's around 30% is responsive to immunotherapy. But I think the neoadjuvant approach gives you a good shot. You give 2 or 3 doses, and then you do not delay the patient for surgery. And during the pathological analysis, you will know whether this is a responder or not. And then you can give adjuvant therapy according to the judgment during your pathological analysis. This is a good tactics before we found a meaningful biomarker for those patients receiving immunotherapy.
Thank you.
Yeah.